Hello, everyone. My name is Michael Soulen. I'm a professor of radiology at the University of Pennsylvania and director of interventional oncology at our Abramson Cancer Center, and also a member of our neuroendocrine tumor program. And today I'm going to talk to you about liver-directed therapies for neuroendocrine liver tumor metastases. So those are my disclosures. The objectives for today are to talk about contemporary outcomes with liver-directed therapies for metastatic neuroendocrine tumors, and also talk about how you might fit liver-directed therapy in with various other systemic treatment options. So why is this important? So neuroendocrine tumors are actually the second most common GI malignancy after colon cancer. So there's a lot of you out there, and we see a lot of you at the hospital here. 9 out of 10 patients with a neuroendocrine tumor will get liver metastases, and it's the most common and usually the only site of disease progression, even for patients who have disease outside the liver, and ultimately is the cause of death in the vast majority of patients who have metastatic neuroendocrine tumor. So controlling the liver is super important. This starts with a biopsy, which is also done by interventional radiologists like me, and this is something that we all pay a lot of attention to. As probably most of you know, neuroendocrine tumors are graded 1, 2, and 3, primarily based on what's called the Ki-67 stain, which tells us what fraction of the tumor cells are proliferating or growing at the time of the biopsy. And we use that information prognostically to kind of predict how you'll do in the long run, but also it helps guide us in terms of the types of therapy that we might want to offer or how aggressive we may want to be. So a biopsy is super important, and folks who come for treatment here at Penn, we will typically biopsy them at the time of liver-directed therapy if they don't have a relatively recent one to pay attention to. So why do we want to biopsy people again and again? Well, we have a database here of 600 patients with biopsies, and among those we had about 250 patients who we had serial biopsies or tissue samples from surgery over many years. And when we looked at those 250 patients, we found was that the grade changed over time. So that Ki-67 number tends to creep up on average about 1% per year, but in individual patients can go up very quickly or not at all. Importantly, if we look at these 250 patients with multiple samples, we found that about 30% the grade actually changed. So the Ki-67 went up enough over time that their grade went from grade 1 to 2 or 2 to 3 or even jumped from 1 to 3. So knowing that the behavior of the tumor can change over time, we do like to periodically resample people to kind of see where their tumor's at in terms of how fast it's growing, since that may affect decisions that we make. Another important point that comes up often is, what about people with disease outside the liver? So typically we're going to do liver-directed therapy in patients where they have metastases to the liver only, or at least that's where most of their disease is. And in fact, as I said earlier, it is the most important site of disease and the most likely to progress. So here we're looking at a surgical series where they looked at 123 patients who had liver metastases but also had extrahepatic disease outside the liver, versus 69 patients who did not, who had liver-only disease. And you can see that at 2 years, 7 out of 10 patients had progressed in both groups, but almost all of those patients had progressed in the liver, and about 2/3 to 3/4 progressed in the liver only, even if they had disease outside the liver. So that's just to bring home the point that controlling the disease of the liver is super important, even for patients who might have lymph node involvement or some peritoneal implants or bone metastases. So how do we treat patients who have liver metastases? Well, if we look at the current NCCN guidelines, the first question we ask is, are you resectable? So could you be surgically debulked? And so for patients who come to me, that's the first question I ask myself when I look at their CAT scan or their MRI is this someone our surgeons could get 70, 90% of the tumor out? And that would be the most efficient way of decreasing the burden of liver metastases. Now, if that's not the case, then if the patient has a low tumor burden and they're not symptomatic, often we'll just observe them with scans every 3 months. Although many people will start octreotide or lanreotide injections right off the bat from the beginning. Now, if they have symptoms or they have a larger tumor burden, not minimal, then we definitely will start them on octreotide or lanreotide right up front and see how they do, again, with scans every 3 months. Importantly, if they have carcinoid type symptoms such as diarrhea and the monthly shots of somatostatin analog aren't sufficient to control that, we can also consider adding talatrestat on top of that, or Zermello it's called, because that will decrease serotonin production and may get symptom control in patients where the monthly injections are not enough. So if those don't work or the patient has progression after those therapies, then we have to think about moving on to the next step. And for patients with liver-only disease or liver-dominant disease, that's going to be some form of liver-directed therapy. So the current NCCN guidelines are that, basically you can get bland embolization or chemoembolization, and currently we don't have any good data telling us that one is necessarily better than the other, so either one of those is acceptable. So how well does embolotherapy work? How does it control symptoms? How does it control disease? What's the price you pay in terms of risk and side effects? And importantly, how long does it last? So it's best for disease control. Patients who are symptomatic from hormone secretion, when you embolize those liver tumors, 75 to 85% of the time the symptoms will go away. They'll knock off enough hormone production, even if it doesn't kill all the tumor, to get rid of the patient's symptoms. So really, really good for symptom control. How about debulking? Well, it's not surgery. When surgery, they try to clean out 70, 90% of the tumor. When we embolize patients and we look at shrinkage, about 55, 60% get what we call a partial response. And a partial response has a specific definition in the oncology world. It means your tumor shrunk by 30% or more. So you're getting that more often than not. Now, for the patients who don't achieve 30% shrinkage, many of them get some shrinkage. They just didn't quite make it to 30%, or maybe they had stable disease. So in the vast majority of patients, embolization will stop progression of the disease. Not in everybody, but most. And many will achieve a partial response. What's the price you pay? Well, it's mostly post-embolization syndrome. Most everybody gets some degree of post-embolization syndrome, which is a combination of pain, nausea, vomiting, fever, loss of energy, loss of appetite that lasts from days to weeks. It can be severe in some patients. 6 or 10% or so will get really bad post-embolization syndrome, meaning that they need either to be returned to the hospital or an emergency room, or they need an elevated level of care. But more serious complications than that are extremely rare, maybe the order of 2%. And then the question is, how long does it last? So it's an important concept to understand is that when you do embolization or some form of liver therapy, it's not just one and done. Like you would never do just like one cycle of chemotherapy or one cycle of PRRT. Similarly, you wouldn't do just one cycle of liver therapy as long as if you recur in your liver, you still qualify for liver therapy, and so you can do it again. So we might do one cycle of embolizations where we're embolizing, however many procedures it takes to embolize all the tumor. Patients respond. They have a duration of response, which typically is around 1.5 years on average, but variable. And then if they progress in the liver only and it hasn't spread elsewhere, we can embolize them again. And we can do it again, and we can do it again. I think my personal record is 16 embolizations in a single patient over 12 years. And so basically you can keep doing cycles of embolization as long as that is the appropriate treatment for your disease. And if we look at a very large series that was recently published out of Paris, France, they had 200 patients with 8-year follow-up, and they made some very important observations. So one thing is the response doesn't change. In other words, for each cycle of embolization, whether it's the first one or the fourth one, the response to the tumor is the same. What does tend to slip over time is how long it lasts. So that first embolization on average lasted about 20 months, but the second round a little over 1 year, the third round a little less than 1 year. But if you add that all up, you're talking 4 or 5 years potentially of benefit without having to go on to another line of therapy. And in fact, that's what they found, that over a quarter of the patients could go 5 years or more without having to move on to another line of therapy. And those that did develop what we call untreatable progression, meaning that we couldn't or wouldn't embolize them again because that wasn't the appropriate treatment, mostly it's because of eventually they had progressive disease. And once you get enough spread outside the liver, we say it's time to switch to some sort of systemic therapy. But very rarely is it because of some technical limitation from the embolization. So keep that in mind, that the duration of benefit of embolization is the duration of benefit of all the embolizations you need, not just the first one. Another thing we learned from that French series was that how well you respond to embolization is prognostic, meaning that the patients who had an objective response, their tumor shrunk by 30% or more, lived about 7 years on average, whereas the patients who only got stabilized disease lived about 4 years on average. Nothing we can do about that, but it was useful information. Now, As you know, there are many flavors of embolization. So there's bland embolization, and then there's chemoembolization, which are probably the two most common techniques. So, and as I said earlier, as far as we know, they work similarly well. But why would you consider bland embolization versus chemoembolization? The most important reasons are patients who have contraindications to getting the chemotherapy drugs. So if you have kidney insufficiency or bone marrow insufficiency, low blood counts, we wouldn't want to add the toxicity of the chemo on top of underlying kidney or bone marrow toxicities. So then I would just do bland embolization in that setting. Sometimes it's patient preference. So some people want the chemo and some people don't, even though we don't really have strong data to argue for one over the other. It's important, however, to recognize that doing bland embolization is not less toxic than getting chemoembolization. In fact, it's worse. So if you look at a large series that we examined looking at data from 8 cancer centers all over the country, we found that the incidence of pain was about doubled with bland embolization compared to chemoembolization or radioembolization. And in fact, in the RETNet trial, which is the big prospective global trial comparing bland embolization to chemoembolization, we haven't reported the results yet because we're just getting to the point now where we can analyze the benefit. But if we look at the toxicity, severe adverse events happen twice as often in the bland arm versus the chemoembolization arm. So just set aside the myth that somehow bland embolization is safer or less toxic than chemo. It's not. What about drug-eluting beads or drug-eluting embolics? Some of you may have encountered these. This is a different way of doing chemoembolization. In the traditional form or the conventional form of doing TACE, you mix the drugs in Lipiodol, which is the oily contrast agent. You make an emulsion, which you infuse in the artery, and it's sucked up into the tumors as a way of delivering the drug into the tumor itself, and then you chase that with a small amount of particles. But an alternative technology is to actually load the drug onto the beads themselves, and that's a technique that's been around since 2010 and should never be used in patients with neuroendocrine tumors. So there were 3 prospective trials, 2 just a single-arm study of the drug-eluting beads, and 1 a randomized controlled trial comparing drug-eluting beads to conventional TACE or bland embolization, and all of them showed severe adverse events rates, a lot of toxicity to the liver and the bile ducts. The 2 single-arm trials were terminated early. The randomized control trial was also had the DEB arm closed early after only 10 patients because 40% of them had major complications. And in fact, the NCCN guidelines now state that you should not use drug-eluting beads in neuroendocrine tumors. So for those of you who are getting care from an interventional radiologist and are considering some form of embolization, make sure you talk to them and make sure that they're not using drug-eluting beads on you because they're still pretty commonly used out in practice. What about radioembolization? Why would you want to use, this is the Y90, the radioactive seeds that we can put in as an alternative to chemoembolization or bland embolization. And, radioembolization is actually using radiation to kill the tumor. We're not cutting off the blood flow of the tumors like we do with bland embolization or chemoembolization. So what are the advantages of it? Well, it's relatively painless and has almost no side effects in most people. People who are too frail to tolerate post-embolization syndrome, or perhaps they're a caretaker for another family member, or maybe they work full-time and can't afford to be out of work. People who, for one reason or another, are not in a good position to tolerate post-embolization syndrome, radioembolization is sort of the kinder, gentler approach. Also, it's safer in patients who've had prior biliary or bile duct intervention. So that's primarily your pancreatic neuroendocrine tumors who may have had a Whipple procedure where they cut the bile duct, or they may have a stent in place to stent the bile duct open through the pancreatic tumor. So those patients have an increased risk of infection if they undergo bland or chemoembolization because there are now bacteria in the bile ducts from the gut, and when you embolize the liver, you also cause microscopic injury to the bile ducts. So with the radioembolization, because we're not cutting off the blood flow, the incidence of infection is less than half of what you see with chemoembolization. So we'll preferentially use radioembolization in patients like that. Radioembolization is also very good as an ablative technique if you have just a single focal site of disease. You can do what's called a segmentectomy, meaning that you only dose 1 or 2 out of the 8 liver segments. You can give a whopping dose of radiation into those 1 or 2 segments, enough to completely obliterate the tumor and that part of the liver. That doesn't come up very often in the neuroendocrine tumor population, but it can sometimes. We also use it combined with chemotherapy for patients with more aggressive disease. So people with grade 2-3 neuroendocrine tumors, especially if there's a component of disease outside the liver, where the oncologists really want to treat that, but they also have a large liver tumor burden. So we'll combine radioembolization with CAP-10 chemotherapy. And those actually work extremely well together and have a very high response rate and very durable response. And so that's a setting in which we sometimes use chemoembolization. A question that often comes up is, well, what's the safety question with doing radioembolization if you've had PRRT before, if you want to have PRRT in the future? And really, there is no data saying that it's not safe to sequence those two in either order. And there's a little bit of data saying that it is safe. So there's been a few small trials reported where people had Y90 either before or after PRRT, and we don't see an increased rate of liver toxicity in those smaller studies. So not quite enough data to say 100% sure it's safe, but we really don't have any strong reason to believe that it's not. So how do you sequence your liver-directed therapies with all the other choices? You could, almost everyone's going to be on a somatostatin analog, octreotide, liraglutide first. That's standard first-line therapy, and people typically will have failed that before they get liver-directed therapy, or sometimes they'll come in with a very heavy tumor burden where we don't want to wait. We need to get that tumor debulked, and so we'll embolize them right up front. But then you have the systemic options. So there's PRRT, there's CAP-10 chemotherapy for the pancreatic nets, there's everolimus or Sutent. So there are a number of systemic choices. And really you have to just sort of look at each patient and figure out, well, in what order do we fire our bullets? And if we look at the data we have a prospective trial of CAP-10 in the United States. That was a study, Econ 2211, that showed a median overall survival of about 5 years. We have the NETTER-1 trial that was a prospective trial of PRRT in small bowel nets that had a median overall survival of about 4 years. And we have the data available on TACE, not really from big prospective randomized trials, but from the available data we have from the French study and the bigger US centers. It looks like 64-month median survival, better than 5 years, and the responder were like 7 years. So it does seem, the data we have available suggests that liver therapy is, a very compelling therapy to use as the next step after failure of octreotide and liraglutide in patients with liver-dominant disease versus going on to systemic disease. And if you look at 5-year survival, again, very, very good after TACE, not as good in NETTER-1, don't really have that data for CAP-10 therapy. So I think that in the United States, it's a pretty common practice that patients who fail octreotide and liraglutide and who have liver-dominant disease, the next line of therapy is liver-directed therapy. And then you save your systemic bullets for later because, eventually if you get 1 to 5 years of benefit after liver-directed therapy, eventually you'll go on and progress elsewhere. And at that point, you're going to need your systemic therapies like chemotherapy or PRRT, and you want to save it for that. This is different from the practice in Europe where they commonly do PRRT as the next line of therapy before they do liver-directed therapy. So I'll just finish up quickly with just pique your interest with some of the research trials we're doing for NET liver metastases. So I mentioned RETNET, that's our big global multi-center randomized trial of bland embolization versus chemoembolization. We finished accruing 2 years ago, so as of this month, we now have 2-year follow-up on every single patient. And so the study's been closed, and we're just cleaning up all the data, filling in all the gaps, and then once that's done, the statistician will do the analysis. So coming this year will be the results, and we'll see whether there really is a difference between bland embolization and chemoembolization. Another ongoing study is our CAP-10 Y90 trial. So I mentioned this combination of chemotherapy with radioembolization for patients with more aggressive tumors. So we did a feasibility and safety study that we published a few years ago, and now we have a multi-center phase 2 trial of about 50 patients to try to validate how effective this treatment is. And I'm pretty excited about this one. It's accruing very well, and our preliminary data just from my single center is that we're seeing progression-free survivals of 3 years with this combination, which even I don't believe is too good to be true. We have another study using what's called a pressure-enabled delivery catheter. So there's most of the time when we're injecting liver-directed therapies, we're just using a microcatheter that goes out that just has a standard hole at the end. But there's a super fancy one that has a windsock type device at the end that prevents stuff from refluxing backwards, enables you to inject more stuff forwards, and also results, at least with some forms of therapy, in higher delivery to the tumors and less delivery to the background liver. So we're doing a trial using TACE where we're comparing this fancy new catheter to a standard end-hole catheter in the same patient. So one lobe gets one lobe gets the other, and we're seeing we're going to get better delivery of our chemoembolic material with the fancy new catheter. TATE is another trial that's about to open. So TATE is like TASTE, so instead of using standard chemotherapy drugs, we're using a different kind of drug called tirapazamine. And tirapazamine is a drug that only is active in the setting of extremely low oxygen, which is what most tumors have, especially when you embolize them and cut off their oxygen supply. So what we're doing is a TASTE-like procedure, except instead of mixing our standard chemotherapy drugs, we're instead infusing tirapazamine and embolizing the tumors to see if that might work better than conventional chemoembolization. And as I mentioned, the biopsy is super important, so we're doing all sorts of research studies on the biopsies we're doing on our patients that come in for embolization, and learning an awful lot of new stuff about the spectrum of genetics and genetic changes in these tumors that may be very helpful in determining new drug therapies that might be effective in this disease. So to sum up, TASTE or chemoembolization provides very durable control of metastatic NET. A series of cycles can benefit people for maybe several years before having to go on to another line of therapy. And contemporary data that we have now suggests that in terms of survival and time to progression, it's probably a little bit better than the existing systemic therapies, at least in the liver, and supports using liver-directed therapy as the next line of treatment after somatostatin analogs for liver-dominant disease. Thanks very much.